everybody, and thank you for joining today's CMS Web Interface support call. During today's webinar, CMS will provide an overview of 2019 CMS Web Interface quality reporting for MIPS groups and ACOs. And after the webinar, CMS will take as many questions as time allows. So now I'll turn it over to Sandra Adams-Slaughter from CMS to begin.
Thank you, Katie. Welcome, everyone, and thank you for joining us today. I'm Sandra Adams-Slaughter from CMS. Joining me on the call today are CMS subject matter experts and contractors who will share helpful information on CMS Web Interface quality reporting and answer your questions during the question and answer session after today's presentation. Today's call will only focus on CMS Web Interface quality reporting. You can contact the Quality Payment Program Service Center with any of your questions regarding cost, promoting interoperability, improvement activities, MIPS, or quality reporting in general. Next slide, please. This is a disclaimer slide about this presentation today. Information in this presentation was correct at the time it is published, but I urge you to use the source documents and links that are provided throughout the presentation, and please stay tuned for any communication from the Quality Payment Program, Medicare Shared Savings Program, ACO, or next generation ACO model regarding updated information. Next slide, please. So the recording, slides, and transcript for the February 5th call are now available on the Quality Payment Program Library webpage. Next slide, please. So here's some CMS Web Interface key dates. The submission period for the CMS Web Interface aligns with other submission types for 2019. The Web Interface opened on January 2nd and will be closing at 8 p.m. Eastern Daylight Time on March 31st, 2020. Your submission will automatically be accepted at submission close. And as a reminder, the CMS Web Interface is accessible using the sign-in link on the Quality Payment Program website, and you can see it circled on the slide. Next slide, please. And here's some additional announcements about upcoming CMS Web Interface support calls. Today is part of a series of Web Interface support calls held weekly throughout the data submission period. The next support call will be held next Wednesday, February 26th from 1 to 2 p.m. Eastern Standard Time. Topics will include FAQs for MH1 and Prev 13, followed by a question and answer period, and additional topics may be added prior to next week's support call. Next slide, please. Here's a reminder that other CMS approved reasons skip requests must be submitted through the CMS Web Interface. This is a way to skip patients attributed to a measure during denominator confirmation. The CMS approved reason is reserved for circumstances that are unique, unusual, and not covered by any of the denominator exclusions or denominator exceptions identified in the measure specifications. Patients for whom a CMS approved reason is selected will be skipped, and another patient must be reported in their place for the measure if available. Next slide, please. This is a reminder that the 2019 CMS Web Interface API application programming interface is available all year for testing in the developer preview environment. You can review the resources listed on this slide for more information. Next slide, please. And now I will pass off the presentation to Angela Stevenson, and she will discuss some frequently asked measure questions.
Thanks, Sandra. Hi, this is Angie with the PIMS Measures team. Our first question is regarding the DM2 measure. Will an HbA1c from a hospital encounter qualify for measure DM2? And yes, it will. As identified on page 5 of the posted measure specification, you should use the most recent HbA1c level that was performed during the measurement period. The next question is on Prep 5. If the patient has a history of a right breast mastectomy and a unilateral left mammogram during the measurement period, would this patient be excluded from the denominator, satisfy the measure, or not satisfy the measure? And mammography screening is defined as a bilateral screening, both breasts of all existing breast tissue. If there is medical record documentation, the patient had a unilateral mastectomy of the right breast, as in your example, then a mammogram of the left breast during the measurement period or the 15 months prior to the measurement period would meet the intent of the measure. There must be medical record documentation that supports the information submitted. Next question is for Prep 6. Can claims data be used to confirm a patient had a colonoscopy at an outside organization? Claims data can be used to aid you in finding the quality action, but supporting medical record documentation is required to substantiate what is submitted. When submitting data through the CMS Web Interface, the expectation is that medical record documentation is available that supports the action submitted. Next slide, please. Next question is on Prep 7. Are flu shots that have been confirmed via claims eligible to meet the documentation requirement? You are not required to provide medical record documentation for the pre-populated influenza immunization data that's included in your sample. However, if influenza immunization data is not pre-populated, then you must have medical record documentation to support that the immunization was administered in accordance with the measure specifications. And the last question is on Prep 10. Since tobacco screening and cessation intervention, if positive for tobacco use, do not need to be completed on the same encounter or need to be completed by the same provider or clinician, is it still true that only the most recent screening should be used to satisfy the measure? The answer is yes. If a patient has multiple tobacco use screenings during the 24-month period, use the most recent tobacco use status. If the patient was determined to be a tobacco user at that most recent screening, then there must be documentation that tobacco use cessation occurred during the 24-month period, which is January 1st, 2018 through December 31st, 2019, for the performance year 2019 to meet the intent of the measure. Thank you very much, and I will return it back to Sandra Adams Slaughter with CMS.
Thank you, Angie. And now we will talk about some resources and where to go for help. Next slide, please. Please note that the 2019 materials providing information on MIPS quality performance category are available on the Quality Payment Program Resource Library. We encourage reviewing these resources if you have questions on quality requirements and measures. We'll continue to communicate any future postings in upcoming support calls. Additionally, the Help and Support page on the Quality Payment Program website contains links to materials such as videos, webinars, and online courses, as well as other items to help with reporting and development. Next slide, please. And here are some additional resources. The Quality Payment Program Webinar Library contains recordings, slides, and transcripts for past webinars, including the 2019 CMS Web Interface user demonstration that was held in November and the CMS Web Interface kickoff call held last December. The recording, slides, and transcript for the January 15th, 22nd, 29th, and February 5th calls are also available on the library. Please note that it may take 1 to 2 weeks to post the presentations to the library following a webinar. Next slide, please. And here are some additional resources for the Medicare Shared Savings Program and Next Generation ACOs. This slide contains links for resources available for the Shared Savings Program and the Next Generation ACO model. Next slide, please. And this slide shows how you can get additional assistance. So please refer to the contact information listed on the slide. Next slide, please. Now, just before we head to the Q&A portion of the call, if you're interested in providing feedback and collaborating with CMS on the Quality Payment Program, we encourage you to participate in our human-centered design efforts. To get involved, please email your name, title, topic of interest, and organization to the email address on the slide. And now I will hand things over to Katie to begin the Q&A portion of this webinar.
Great, thank you, Sandra. All right, so now we are beginning the Q&A portion of this webinar. If you would like to ask a question, please submit it through the questions tab on your screen, and we can read it out loud. Or, of course, if you'd like to ask a question over the phone line, please raise your hand as shown on the screen, and we can unmute your line. All right, so the first question asks, at one of the previous support calls, you said that for PREV 12, a statin allergy or intolerance had to be documented in the measurement year. Our providers add statin to the allergy or intolerance list at the time that the allergy or intolerance is noted, and because this is a living document, the allergy or intolerance is available to the provider at the point of care. Will this still meet the measurement requirement?
Good afternoon. This is Deb from the PIMS team, and I want to point you to page 14 of the posted specification. There are a few things to keep in mind with the denominator exception for PREV 13, and also to clarify, this is for PREV 13, the statin measure. The first guidance note does have to do with mapping. So for mapping from the EHR, when an acceptable drug allergy code is found, you would look for the drug classification with a yes conditional. These drugs can be used as a denominator exception if present in the patient's record, accompanied by an appropriate conditional reason why the patient isn't taking the drug. For example, an adverse effect, allergy, or intolerance to statin medication. But then further down in that guidance, you will also find that the denominator exception should be considered active during the measurement period. So the fact that somebody may have been allergic to a statin 10 years ago is not a reason for statin medication not being prescribed. It should be something that is, again, considered active during the measurement period. So your documentation would need to reflect that in some shape or form. Thank you.
Great, thank you. All right, your next question asks, for MH1, if there are two PHQ-9 results documented on the same date, which result is used?
Hi, this is Katie from the PIMS team. So you would enter the first instance where the PHQ-9 is greater than 9. Thank you.
Great, thank you. All right, next is also about MH1. For MH1 timing for exclusion, is it any time in the patient's history prior to the end of the MAP, or is it only during the denominator identification period up to the end of the MAP?
Hi, this is Katie again. So the exclusions encompass the denominator identification period through the measure assessment period. So the exclusions do not apply to any time in the patient's history. It's truly limited to those 2 dates. And just to emphasize, they do require that the diagnosis for one of those exclusions is active. So there must be, the diagnosis on the patient's problem list, a diagnosis code description listed in an encounter, or is documented in the progress note indicating the patient is being treated or managed for the disease or condition. So just to reiterate, this time frame could be different for each patient depending on that index date and then the subsequent measure assessment period. Thank you.
Great, thank you. All right, another question for Prev 13. In the event a patient on a statin during the measurement period is on a statin during the measurement period, however, the patient develops an intolerance during the measurement period, do they report the taking of statin or the intolerance?
So this is Deb from the PIMS team again. And since we're talking about a denominator exception, denominator exceptions do not have to be selected. So therefore, if you have determined the patient was either taking a prescribed statin therapy during the measurement period or was prescribed statin therapy during the measurement period, you can select yes, the patient is taking or were prescribed statin therapy. Thank you.
Great, thank you. All right, regarding exclusions for long-term care, if we have documentation in the medical record that the patient is permanently residing in a long-term care facility but has no POS code, can we exclude the patient from these measures?
Hi, this is Angie from PIMS. Yes, you can. You are not required to have documentation of the place of service codes. They are provided in the measure specifications just to help you determine the type of long care facilities for the exclusion and to help you locate the place in the medical record where there may be documentation that the patient resided in long-term care during the measurement period. So you may select it if you have documentation that they were in nursing facility, custodial care facility, hospice, or intermediate care facility / intellectual with disabilities facility. A note that the denominator exclusion does not include place of service 31 for skilled care. Thank you.
Great, thank you. All right, and just a reminder to everybody on the phone line, if you'd like to ask a question over the phone, please raise your hand on the go-to menu, and we can go ahead and unmute your line. So at the moment, we do have one question on the phone line. It's by Lauren Sweeney. So Lauren, we're unmuting your line, and you can go ahead. Lauren Sweeney, you can go ahead and ask your question.
Okay, thank you. So I'm wondering, this is in regard to the hypertension measure. If the diagnosis is in a resolved status on the problem list during the measurement period, and the only reference to that diagnosis is a lab claim, should that be considered a resolved or not resolved? So the providers are not using that anymore. They put it into a resolved category.
So this is Katie from the PIMS team. For hypertension, the denominator confirmation calls for patients with a documented diagnosis of essential hypertension within the first 6 months of the measurement period or any time prior to the measurement period, but does not end before the start of the measurement period. So if the hypertension resolved during the measurement period, that patient should still be included because it was still active during the measurement period. Does that help clarify?
Not really. So there's no resolve date. Should I assume that it's still, even though it's been labeled resolved, if there is no date, should I assume that it's not resolved?
In terms of, for your measure documentation would need to support the information that's submitted. So if you don't have documentation truly supporting that the diagnosis is resolved, it would likely still be viewed as an active diagnosis. But again, that is something that would be more up to your organization to determine if you have the appropriate medical record documentation to support whether the diagnosis was active or resolved, and subsequently report appropriately.
Okay. Okay, thank you.
Great, thank you. All right, your next question asks, for Prev 13, is Repatha able to be used as a statin?
So this is Deb again from PIMS, and I'm going to point you to page 6 of the posted specification. There is a numerator note that refers to current statin therapy. Basically, only statin therapy meets the measure numerator criteria, not other cholesterol lowering medications. So you would need to determine if the medication that you are referring to is considered statin therapy and not just cholesterol lowering medication. Thank you.
Great, thank you. All right, next question asks that on one of the slides, it indicated that claims data could be used to support Prev 6, but that medical record documentation needed to be there to support. What about patient-reported documentation? If a patient states that they had a normal colonoscopy within the required time frame, do we have to attempt to locate the documentation to support?
Hi, this is Angie. I'd like to clarify the slide, and it was not saying that claims could be used. We can bring that up again if we like, but it is saying that claims data can be used to aid you in finding the quality action, meaning medical record documentation that the colonoscopy was performed, with the date and so forth. So really the answer is no, claims data cannot be used solely to confirm a colonoscopy. And then you asked about the patient-reported colonoscopy, and for that, it just needs to have the year of the colonoscopy and the type of test, of course, and the result, whether it's normal or abnormal, or some type of result documented. Thank you.
Great, thank you for that clarification. And you can see that we have pulled that slide up for further reference. All right, so we will go back to the phone line. So Joseph Bartman, we are unmuting your line. And Joseph Bartman, you can go ahead and ask your question.
Thanks. So in relating to influenza, if we have a provider who's documenting on multiple occasions that the patient is declining all recommended health maintenance, including immunizations, does that meet the intent of patient refusal as it relates to the influenza vaccine?
Hi, this is Jamie with the PIMS team. Can you please submit this question into the help desk at qpp@cms.hhs.gov, and we can go ahead and take a look at this and give you a response.
No problem. And I can put the actual what they wrote in the chart, so you guys clearly can see what it's stating. But thank you.
Okay, thank you.
All right, great. Next question concerns Prev 12. It's asked to please confirm if the depression screening has to be documented on the same date as the office visit.
Hi, this is Katie from the PIMS team. So I'm going to direct this question to page 10 of the measure specification. So a patient may have access to the depression screening tool in advance of the appointment. However, the depression screening results must be documented on the date of the encounter, which is the date of the appointment. So the results must be reviewed and verified and documented by the eligible professional in the medical record on the date of the encounter to meet the screening portion of the measure. Thank you.
Great, thank you. All right, next question asks for MH1, if we don't have enough beneficiaries that meet the minimum requirements, what is the process to fulfill the protocol?
Hi, this is Aslam. If you have less than 248 beneficiaries ranked for a measure, you must report required data for all beneficiaries in that measured sample. So if you have only 50 beneficiaries in a measured sample, you need to report the required data for those beneficiaries that are in the sample. Thank you.
Great, thank you. All right, we will go back to the phone line. Lucilia DeRosa, we're unmuting your line. So, Lucilia DeRosa, you can go ahead.
Hi, how are you?
Great, thanks. You may go ahead.
I actually just have a question. We have a member that's in the Prep 5 measure that's actually holding up the whole measure. In the system, they have him listed as a female. His name is Francisco Cadero. We've submitted a ticket to the QPP system, but according to them, we got a response back that saying we can edit the demographic information to the CMS Web Interface, which we've done, but it's not taking it. So we submitted a ticket to the help desk, I believe on February 7th, I'm sorry. And we haven't heard back. So I don't know if there was any way that someone could actually look into this because it's holding up that measure.
Sorry, could you please repeat that question? We couldn't hear the full question.
Yes, and this is Sandra. Please do not share any protected information.
Mm-hmm. We just want to know who can expedite the ticket because, like I said, we submitted it again to QPP at CMS on February 6th, and we haven't heard back.
Hi, this is Azam. I believe you said you have opened a ServiceNow ticket and you haven't heard back. If that's the case, if you could share the ServiceNow ticket number in the chat, we will look into that and get back to you. Hope that helps.
Okay, great, thank you. Again, Lucilia, if you could submit your ServiceNow ticket, we will forward that. All right, next question is on Prep 13. Can you please repeat the limited period that denominator exceptions are acceptable?
Absolutely. This is the guidance is provided on page 14 of the posted specification. Documentation of the exception should be active during the measurement period. Thank you.
Great, thank you. All right, next is a clarification on the Prep 7 clarification given today. They called into the QPP help desk, to verify that claims data can be used in verification, which was confirmed. The issue was then brought up when analytics software was automatically closing this measure based on claims data. It is our understanding that this is not acceptable unless pre-populated in QPP. But when they called the help desk again, they were told it was acceptable. Please, can you clarify?
Hi, this is Jamie with
Andy from PIM. Sorry, Jamie. I was just going to say I have the case up that was in question, and it looks like there was maybe some misunderstanding from another team. So we could offer to reopen that and address the question through the help desk unless you had something to add, Jamie. Sorry. Thank you.
That sounds like a plan. Thanks.
Okay, great. All right, we'll go back to the phone line. Shelly Simpson, we're going to unmute your line. So Shelly Simpson, you can go ahead.
Hi, this is in regards to Prep 7. Can you guys hear me okay?
Yes, you may go ahead.
Okay. I know previously in this call when people were saying patient had reported, you had specified for Prep 7 that with some of the more questionable ones, they had to have the month. But according to the actual document here, documentation of patient-reported previous receipt of influenza immunization is acceptable during the flu season. Our scenario is, for core measure, we actually set up our screening where it specifically says if the patient comes into the hospital, have you had a flu vaccination this season? And then the patient, they answer however. So if I have a scenario where the patient comes in on October the 31st, and this screening specifically says, have you had the flu immunization this season? The patient says, yes, had this season prior to admission. Is that still unacceptable? Do they have to say, I had it in September, October? Because according to guidelines, that's okay if they specify this season and it's during the season.
Hi, this is Jamie with PIMS. If it's possible, could you also submit this question as a help desk question at qpp@cms.hhs.gov so we can take a look at that and really sort of weed through that scenario?
Okay, thank you.
Thank you.
Okay, great. As a reminder, we are accepting phone questions, so please just go ahead and raise your hand and we can unmute your lines. In the meantime, we had one more question come in regarding an answer that was earlier provided on MH1 regarding exclusion criteria timeframes. On page 10 of the narrative spec for MH1, the spec says that the denominator exclusion diagnoses can occur anytime prior to the end of the measurement assessment period. So can you please clarify?
Hi, this is Katie from the PIMS team. So yes, just wanted to address this again. Also on page 10 of the measure specifications, it does state that there must be an active diagnosis associated with one of those denominator exclusions. So just to reiterate, an active diagnosis is defined as either on the patient's problem list, diagnosis code, description listed on the encounter, or is documented in the progress note indicating the patient is being treated or managed for the disease or condition. So they have to have that active diagnosis during the denominator identification period through the end of, or up until the measure assessment period. So you have that 12 months plus or minus 60 days as initiated by the index date to determine whether or not there's an active diagnosis applicable to one of those exclusions. Thank you.
Great, thank you. All right, next question concerns Prev 7. In the event that a patient received a flu vaccine during the flu season and received palliative care at the end of the performance year, are they then required to be removed from the denominator?
Hi, this is Jamie with PIMS. Thanks for the question. Yep, this looks like it could be a medical exception. Therefore, as long as that is documented within the medical record during the flu season, that would be applicable. Thanks so much.
Great, thank you. All right, next question. For Prev 13, does the ASCVD or diabetes diagnosis have to be active during the measurement period? For example, if a patient had a diabetes diagnosis that was resolved in 2018, but they had an LDL greater than 70 in 2019, would that patient still qualify for the measure?
So this is Deb, and I had that specification pulled up. Here we go. What I would recommend for Prev 13 is to definitely go through in a step-by-step fashion to determine the denominator eligibility. So the first thing you are going to determine is if they have a clinical diagnosis of ASCVD. If you are getting all the way into patient population number 3 on page 6 does say that they have type 1 or type 2 diabetes in the measurement year. And let me go, if you go down into the actual denominator criteria of each of those, it will provide some additional information. So for the criteria for diabetes in patient population 3 on page 12, it does say that the diagnosis of diabetes is defined as any history of diabetes prior to or during the measurement period. So again, I would look at those specifications. If it doesn't give you the specific time period within the first couple of pages, if you get into the submission guidance, the denominator and the numerator, those time periods should be identified there. If you have additional questions, please feel free to submit another one, and I will try and get to those questions as well. Thank you.
Great, thank you. All right, your next question asks, with measure MH1, is it acceptable to report less than 248 patients if a small number is the only number of patients who satisfy the measure?
Hi, this is Aslam. If you have less than the minimum required number of beneficiaries, which is 248, please do complete all the beneficiaries that you have in that measured sample to meet the reporting requirement for the measure. Thank you.
Great, thank you. All right, your next question asks, if we have recorded through CMS claims that a patient is deceased, should we skip them, or does the death need to be indicated in the medical record in order to skip the patient? It was not indicated in the medical record at the time as it is out of network.
Hi, this is Katie from the PIMS team. I think we might need some additional information in order to answer this question appropriately. So we're actually going to direct the submitter to submit their question to qpp@cms.hhs.gov. Thank you.
Great, thank you. All right, your next question asks, historically, guidance from CMS was provided that patient-reported colorectal screening required month and year, along with results in the chart. Currently, we have now heard on a couple of recent calls that it is now only the year that is required. Can you clarify if the month is no longer required?
Hi, this is Angie with PIMS. I'm sorry, could you repeat which measure that question was for?
Hi, Angie, it's for colorectal screening.
Oh, okay. PREV 6 for colorectal cancer screening.
Yes.
It tells in the measure specifications what is required, and it's going to depend on the type of test to determine if it is in the proper time frame. Colonoscopy has to be during the measurement period or the 9 years prior. If it is a different type of test that might require to show the months to substantiate that it was in the proper time period, then it would be. And I'm sorry, I think all of these are for years. So if you look on page 8, under the numerator guidance, it does say that the patient reported requirement is date, in parentheses, year, and type of test, and result or finding. You can find that then on page 8. Thank you.
Great, thank you. All right, and I believe, Jamie, you would like to clarify a question about influenza high-dose vaccine from September 29, 2017, which was deferred as the patient will get at PCP.
Yeah, thanks so much. This is Jamie with PIMS. I'm not sure exactly the nature of the question if you're speaking to numerator compliance. So if you could either clarify the question in the queue or go ahead and submit a help desk question at qpp@cms.hhs.gov. That would be really helpful, and we'll go ahead and get a response for you. Thanks.
Great, thank you. All right, your next question asks, for DM2, if the date and result of an HGB-A1C is pre-populated in LightBeam for a beneficiary, but you cannot locate medical records for that service, how should this be classified?
So this is Deb from the PIMS team, and you may need to provide some additional information on this if I don't quite answer your question. Basically, your medical record documentation needs to be able to support for the numerator compliance that the patient had one or more hemoglobin A1C tests performed during the measurement period. You also need to be able to record the most recent date the blood was drawn, and that includes the month, day, and year. And then additionally, to be able to record the most recent hemoglobin A1C value. If that doesn't answer your question, if you could go ahead and provide some additional detail, and I'll try and come back to that. Thank you.
Great, thank you. We will let you know if more details provided that we can discuss on today's call. Also, as a general reminder to everybody on the phone, if you do have a question that you would like to ask, please feel free to submit it through your chat box and we can read it out loud. Or as always, you can go ahead and raise your hand. At the moment, our final question asks, historically, guidance from CMS was provided that patient-reported colorectal screening required month and year. Sorry, this was already asked, but it looks like they missed the question. Can you please clarify whether the month is no longer required and only the year is?
This is Angie. Could you submit your question to the QPP help desk and we can get you exact answer? I had quoted the patient reported requirement, and then the specs also saying the note indicating the date the screening was performed and the results or findings would be for non-patient reported. But we could look into this and make sure we have the correct answer for you if you would submit a ticket, please. Thanks.
All right, great, thank you. Again, the question period and portion of this webinar is open for another 15 minutes. If you'd like to ask a question, please submit it. So we'll give it a few minutes to see if anything new comes in. All right, we have a question over the phone line. Nicole Caliendo, we're unmuting your line. All right, so Nicole Caliendo, you may go ahead.
Oh, I'm sorry. I clicked on the hand by mistake.
Not a problem. Thank you anyway. All right, your next question concerns HTN2. If the patient has no diagnosis of I-10 essential hypertension, but has a history of unspecified hypertension or any hypertensive disorder that is not specifically I-10, will the patient qualify for this measure?
So this is Katie from the PIMS team. We would encourage you to take a look at the hypertension coding document for the applicable diagnosis associated with confirming the diagnosis for this measure. So the measure does call for essential hypertension, and I think we would need some more details in regard to your specific question to confirm, specifically whether or not that meets the intent of the measure. But just to reiterate, they do need a documented diagnosis of essential hypertension within the first 6 months of the measurement period or any time prior. And then again, take a look at that coding document to ensure that the diagnosis is present there in order to confirm. Thank you.
Great, thank you. All right, next question asks, if the last vitals of the year are clearly entered in error, for example, 18/65, do you enter those values or move to those previous?
So this is Katie from the PIMS team. I believe this is actually a case that's open currently within the service center and is taking a little bit of investigation on our part. So we would ask that you stay tuned for response to that open service center question in order to receive an accurate response on this one. Thank you.
Great, thank you. All right, your next question concerns PREV 13. If a statin medication was active in 2017 or 2018 but was discontinued prior to 2019, would the medication still count?
So this is Deb from the PIMS team, and the answer to that is no. If you have been able to confirm that the patient would be considered denominator eligible for the measure, you would need to find some time within the 2019 program year that the patient was actively using or received an order or prescription for statin therapy. Thank you.
Okay, great, thank you. Looks like we do have one question on the phone line. So Ashley Jewel Darlington, you are now unmuted. So Ashley Darlington, you may go ahead.
Okay, can you guys hear me okay?
Yes, you may go ahead.
Okay, great. So I asked the question earlier about the MH1 fulfilling the protocol. What I'm running into, and hopefully I can get clarification, is if a patient is diagnosed with depression during the denominator identification period, and then the providers are not following up with the PHQ-9, those patients are getting skipped. So my question is how do we then fulfill this requirement when we are continually getting patients skipped?
So this is Katie. I may need a little bit further clarification. So are you saying that they had the appropriate diagnosis but did not have an initial PHQ-9 during the denominator identification, or they didn't have a follow-up in the 12 months plus or minus 60 days?
Yes, exactly. So in the follow-up period, generally in the annual wellness, there is an initial PHQ, but then the follow-up. So if there's no follow-up, then those patients are continually skipped. So I'm having a hard time fulfilling the minimum requirement.
Sure. And so just, purely based on the measure specification, if they do have, the appropriate diagnosis with that initial PHQ-9 that marks the index date, the numerator does require documentation of that PHQ-9 in the measure assessment period, which is that 12 months plus or minus 60 days from the index event. So if they did not have one or more PHQ-9 administered during the measure assessment period, you would have to report no for those patients, and it would be considered performance not met for those folks.
Okay, so continue along even though I'm getting multiple skips.
Right, yep. If there's not documentation to support that they received that follow-up PHQ-9, there's no other options for reporting other than yes or no as to whether it was completed.
Okay, and so then my second question is, once I get to the end of this reporting, then what happens? So is it just mean that there's not a minimum that's met?
So
this would be a question. Oh,
Katie, can we go back
go ahead.
And only because you're talking about skipping, and I think what Katie's trying to say is you're really not skipping a patient, but I think what might be happening, again, if you have somebody that meets the denominator criteria based on the diagnosis, are you also finding during that index period a PHQ-9 greater than 9 to do that completion of confirming denominator eligibility?
Well, sometimes, not always.
Okay. So if there is not, and that's where the difference lies. So if you have somebody who's denominator eligible, you have the diagnosis, you have the PHQ-9 greater than 9, and finding in the follow-up, they do not have a PHQ-9 less than 5, that's not a skip, that would be a performance not met. On the other hand, if you have a denominator, you've confirmed the diagnosis, but there's no PHQ-9 greater than 9, that one would skip. And in that case, what a lot of people run into is they will go through their entire sample, and because maybe there's not a PHQ-9 used at all, or they don't find that many PHQ-9 greater than 9 results, that results in a lot of skips, and you may have to work your way through that entire patient sample until you've reported on 100%. And then if we have in the past had some people that they don't use the PHQ-9 at all, so they skipped their entire patient sample, and that's fine. You've completed it. You've done what you could do.
Okay, great. That answers my question. Thank you.
Thank you.
Great, thank you. Next question concerns MH1. If the patient answers all of the questions but does not tally the score and the provider miscalculates the initial result in the notes during the audit, can it be manually recalculated and that number used?
Hi, this is Katie from the PIMS team. This particular question we would also suggest sending to qpp@cms.hhs.gov. Thank you.
Great, thank you. All right, your next question. As for clarification, for the 2019 MH1 coding document, it says that it doesn't list any ICD-9 codes for the denominator, but does list ICD-9 codes for the denominator exclusions. Are ICD-9s accepted for the denominator? And if so, where can those be found?
So this is Katie again. So excuse me, for MH1, you would need the appropriate medical record documentation as outlined in the measure specifications to support what you're reporting. So in terms of mapping to the coding documents, those are all inclusive if you are mapping to an EHR. However, any medical record documentation can be used to support the appropriate diagnosis for the measure. So with that said, there are some instructions within the narrative specifications on specific language and a diagnosis code usage that can be found on page 9 of the measure specification. So the following are ways that you can use to confirm the diagnosis of major depression or dysthymia. Either a diagnosis code on the encounter or a problem list, and that's regardless of the vendor assigned description of the code. You can also look for the words major depression, major depressive disorder, dysthymia, dysthymic disorder, pervasive depressive disorder on the progress notes or problem list to confirm the diagnosis. In addition, paper records, the description diagnosis can be used with the option to confirm billing, by billing code. So we would suggest, ensuring your documentation maps to those appropriate ways to confirm the codes. And then if you need additional assistance, you can always submit that question to qpp@cms.hhs.gov, and we can help you through that further. Thank you.
Great, thank you. All right, your next question asks for clarification on Prev 6. They note that if there's an encounter in May of 2019, which states that there was a colonoscopy 8 years ago in normal, would it be appropriate to capture this screening and use the year 2011?
Hi, this is Angie with PIMS. I think that was probably a question that I can answer. Can you repeat the measure and the question for me?
Of course. It's for Prev 6. It asks if there was an encounter in May of 2019, which states that there was a colonoscopy 8 years ago in normal, would it be appropriate to capture the screening and use the year 2011?
As long as the medical record documentation can substantiate that the colonoscopy was performed during measurement year or the 9 years prior, then yes, it can be used. Thanks.
Great, thank you. All right, and your next question is for HTN2. The measure specs use the words diagnosis of hypertension. However, the coding documents use the word essential hypertension. Is hypertension only enough to meet the denominator?
So this is Katie from the PIMS team. Again, the denominator does call for a diagnosis of essential hypertension. So just verifying with the word hypertension in your medical record would not truly be enough to confirm the appropriate diagnosis. So you would need to ensure or maybe take a look and see if you have further documentation that would be able to confirm that diagnosis of essential hypertension within the appropriate time frame for the measure. Thank you.
Great, thank you. All right, and your next question asks, if the provider documents hyperlipidemia and the code is for familial or pure hypercholesterolemia, is that acceptable even though the correct code is used?
So this is Deb from the PIMS team, and because this is getting into some of the specific documentation requirements, I would recommend going ahead and opening up a ServiceNow help desk question. The thing about the coding is the coding is considered all-inclusive. You can use the coding to confirm that the patient should be meeting the intent of the measure, and in this case, the intent of one of the populations considered denominator eligible. And this may go back kind of to a question that was asked last week, and we will continue to provide clarification on this. There are times we can't tell you exactly what a provider meant when they wrote something in a medical record, and it may be necessary for you to confirm what was intended by that documentation. In no way, shape, or form are we suggesting that medical records are updated at this point in time. But, just being aware that there are some things in the medical records that if you're not sure what the intent is, we certainly can't answer that. And you would want to ensure that you have the proper documentation to confirm the patient should be included in that denominator. And the main reason for that is just to ensure that you're being held accountable to a quality action that is relevant for that patient. So if you have additional information, please feel free to open up a ServiceNow inquiry and we can provide some additional guidance or point you to the measure specification for your specific case. Thank you.
Okay, great, thank you. And it looks like that's all the time that we have for Q&A today, so I will pass it back to Sandra to close out.
Thank you, Katie, and thank you everyone for joining us today. The slide deck recording and transcript from today's call will be available on the QPP webinar library in the next 2 weeks. As a reminder, our next support call is scheduled for next Wednesday, February 26th, from 1 to 2 p.m. Eastern Time, during which we'll cover assignment and sampling frequently asked questions, as well as frequently asked measure questions for MH1 and Prep 13. We hope you'll join us. Thank you.